Do you, a family member or somebody you know suffering from critical illness, do you want to know how palliative care can definitely bring relief and comfort? Do you want to know from a very experienced guest what palliative care means and how is it different compared to many other treatments? Well, if you answered yes to any of these questions, I would like to welcome you on this podcast of the Cancer Conversations podcast with Coach Wanda. Today's episode is about relief and comfort, how palliative care enhances the quality of life of cancer patients. If you don't know me yet, allow me to introduce myself. My name is Wanda Lintan Kalupig. I am the 2021 number one most influential Filipina on LinkedIn and 2023 top 15 LinkedIn expert in Dubai. Every week, I go live on LinkedIn. This is my over 100, I think this is my 110th episode. But today we're talking about palliative care. Before I bring my guest on the stage, let me first invite you. I'm very blessed to be part of the Meant to Be Well Summit because October is all about mental wellness, right? So together with Ambri Nadim and people all over the world for 48 hours, we're going live. And my topic is about from evolution to exhaustion. How can you overcome burnout? So watch out for that. Also, let me just do a recap in case you miss the episodes of our previous conversations podcast. Well, let me tell you, last week I'm very happy to have Janita Green from the US. She is a two-time breast cancer survivor. So we spoke about how can you find light through the darkest days of cancer. We had over 180 plus people who registered for this event, but go to Linktree Coach Wanda to get access to the recording. You can access it both either on the YouTube channel or you can also access it in my LinkedIn profile. On episode 7, I had another guest, another doctor who actually shared how advanced testing that BioArrow is doing is transforming cancer diagnosis and treatment. There are many, many diagnoses, right, in terms of how you detect sickness, but in this episode, we spoke about liquid biopsy and the advancements in technology that can definitely help patients. So again, go to LinkedIn Coach Wanda to watch the recording of that episode. Now, also, on one of the episodes that I had, that's episode 6, I had my guest. He's from Saudi, Liwa Abukit. We spoke about how Touch Pay is transforming healthcare payments. Here in the UAE, we have Tabi. We split the payments for shopping, right, through Tabi. But Touch Pay is disrupting healthcare by helping them on the payments. So watch this episode and understand how Touch Pay is transforming. Right now, they're available in Jordan, but they are hoping to expand soon. If you want to partner with Touch Pay to disrupt transformation of the healthcare payments, please do in touch and reach out to Liwa. And also on episode 5, wow, this is a very inspiring story. George is from Australia. He was diagnosed with cancer at the age of 31. He had cancer all over his body, but only his bone marrow was exempted. At 39, he also had a brain injury and he was like a vegetable already. But now at 48, George is at the happiest and healthiest version of himself. On this episode of conversations about hope, George shared every tool and technique he used, mindset, the body, the food, everything, all that he did to overcome and beat cancer. So please do watch that. Go to Linktree Coach Wanda to get access to that recording. Also, another powerful episode on episode 4, I used to be stressed and sickly. That's why I know how our stress in mind and body is really giving us sickness. So on this episode with Coach LJ, an emotional transformational coach, she shared how every negative emotions that you have lead to sickness and what are the tips and tools that you can immediately apply so you can overcome and beat stress. Now on episode 3, one of my staff Rose shared how together she is managing the cancer of the husband. And I think it's an emotion. Cancer is so complex. That's why it's a big C. But in this episode 3, Rose really put her heart out and shared how can you really help a family member who is actually battling with cancer. And on episode 2, wow, this is another episode that is one of my favorites. We spoke about how can you heal cancer holistically. I mean, we spoke about there's so many things now that can heal any sickness. I mean, even cancer have so many therapies, but Dr. Rami, for the last 20 years, I've seen over 24,000 patients, and many of them are cancer patients. And he shared on this episode how healing cancer holistically other than medicine, what are the alternative therapies to help heal the mind, the body, and the spirit. It is a very interesting episode. Please do watch that. Again, go to Linkly Coach Wanda to watch the recording. Also, this is the first episode. Dr. Huria is the first Emirati breast cancer surgeon. And on this episode, we spoke everything about breast cancer. In this episode, Dr. Huria said that every woman, specifically above age 40, needs to be checked because breast cancer is the number one cause of cancer for most women, but it's also the most curable and most effective. And as a good news, I actually have some good news. Advanced Care Oncology Center in Al Farjan here in Dubai, UAE, is giving free mammogram this October. And this is up to November 30, 2024. Please book through these numbers so you can get this free. Now, if you have no time to go to Al Farjan, there's another good news. Also, Prime Medical Center, for only 250 and 300, you can get yourself checked on all Prime Medical Centers for breast cancer mammogram. So, today, back to my episode, we had a recap, but I'm very, very excited because even before starting, Dr. Neil and I shared a lot of information already. He's such an expert. I think there's so much wisdom that you need to learn about palliative care that a lot of people are missing. So before I bring Dr. Neil on stage, let me introduce him first. Dr. Neil Nijhawan is a renowned consultant in palliative medicine. He is the chairman of the UAE Palliative and Supportive Care Working Group and a clinical associate professor at Gulf Medical University. With a focus on enhancing the quality of life of patients with serious illnesses, Dr. Nijhawan specializes in pain management and symptom control. At Gulf Medical University, he educates future healthcare professionals and contributes to research on innovative palliative care practices. Dr. Nijhawan is dedicated to holistic patient-centered care and actively community engagement, making him a respected leader in his field. Wow. So let me bring Dr. Neil on stage. Hi, Doctor. Thank you
Hey,
again
how are
for
you?
saying yes.
Thank you for having me.
It's an honor, Doctor. Now, I think, Doctor, it's good to understand first about your humble beginnings. I mean, I understand how doctors choose what kind of practice they do, right? Now, maybe you can
Mhm.
share a bit of story. What brought you to palliative care?
So, again, thank you so much for having me. First podcast. I trained as a doctor in the UK, and my training, like many doctors, was focused on medicine. I decided very early on that I wasn't going to be a surgeon. Um, and so while I was training, we do different things. You do some time in cardiology, you do times in all the different disciplines. And by the time I came to figuring out what to specialize in, I was a little bit lost, to be honest. My boss at the time suggested, she goes, well, have you considered palliative care? And it just hadn't occurred to me at all. So I spent some time with the palliative care team in London. And in doing that, I realized very quickly this was what I was supposed to do. And there was one sort of defining moment. I remember I had just qualified. I was working as a doctor in London, and this was a long time ago. And I was doing surgery at the time, and we would finish seeing the patients early in the morning with the surgeon. And then after that ward round was finished, he would then say, okay, I've finished seeing my patients. There are 4 or 5 patients who were dying. He says, I'm not going to see them. You see them.
Mm,
That's your ward round. And so from that very, very early stage, I realized that medicine didn't always treat patients who were dying or coming to the end of life very well. And that stuck in my
mm,
mind. And over time, I realized that actually I like spending time with these patients. You get a lot of exposure, you get a lot of experience from dealing with patients who are dealing with mortality. And actually,
Mm,
why do people go into medicine? You want to help people. What better
true.
time to help patients than those who are actually approaching the end of life? So you have a real golden opportunity to do something meaningful in medicine. So for me, I'm very, very happy that I chose palliative medicine. I'm very comfortable with what I do.
Thank you, doctor. I think, it's so scary to talk about death and mortality, right? I think that's why when you choose to be in palliative care, I mean, I know this is something that you have to have a very strong personality to manage because you
Mhm.
know that this is towards the end of life already. Now, doctor, maybe you can explain a bit of history about palliative care because in the beginning, I mean, when backstage you were explaining to me, palliative care dates back, centuries ago. Maybe you can tell a bit of story about palliative care first.
Sure, sure. So if you do a Google search and you look up the history of palliative care, it'll take you as far back as the time of the Crusades. So at the time of the Crusades, medieval Europe, there were things called hospices that looked specifically after patients who were dying, whatever they were dying from.
Mm,
This is where the concept of hospice grew out from. And it was often associated with religious orders, Christianity predominantly in Europe. But more recently, in sort of more contemporary history, the sort of modern hospice movement started after the Second World War in
mm,
London. And this is where sort of Dame Cicely Saunders came onto the scene. She set up a hospice in southeast London called St. Christopher's Hospice. And I spent some time there as a medical student. And this is where the modern hospice and palliative care movement started. So palliative care as a concept has been around for a long time because unfortunately as humans we all die. So
mm.
there's always something to do, always some specific focus on particularly patients who are coming to the end of life. So I guess I should say palliative care has been around for a long time, but as a medical specialty, it's only really the last 30 years that it has gained some prominence.
Mm. I think it's important, because a lot of people like palliative care. Are you giving up already?
Mm.
I mean, that's the connotation, right? Which actually brings me to the next question. Maybe you can, doctor, expand further. How is palliative care different compared to the other treatment? And let's make it specific first. I mean, I know this is not just cancer, but in general, how does palliative care differ from other traditional treatments?
So it's important to say that palliative care doctors are doctors. I trained in internal medicine before I specialized in palliative care, and most palliative care doctors train in internal medicine or family medicine first, primarily because you need as broad an experience as possible. You need as
Hmm.
much training in medicine before you start doing palliative care. So the way we describe palliative care, and this is a very simplistic way of describing it, but I think it highlights the importance. Palliative care is essentially the medical care that you would want if
Hmm.
you or somebody you loved or cared about was dealing with a life-limiting illness. It doesn't
Hmm.
necessarily mean you're coming to the end of life, but if
Uh-huh.
you or somebody you love is so sick that there is a
Yeah.
risk of dying, you want
Hmm.
palliative care involved in their care. And the
Okay.
reason palliative care is useful is because the focus of palliative care is to focus on quality of life. It doesn't
Hmm.
mean that we don't treat what can be treated.
Yeah.
But while that treatment is going on, we try very hard not to lose focus on what does the patient want? What does the person in the bed want?
Yeah.
What is important to them? And while we're
Hmm.
figuring all of this out, we also try and improve quality of life by making sure the patient feels well. So we deal
Hmm.
with all the physical and psychological symptoms. That's the importance of palliative care.
I love that because I think, doctor, I mean, during when my mom was in the hospital, I know it's about medicine, 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 but there's so much psychological support that she needed at that time. Like, when I was talking to her, there were some points just like, you will not understand, you're not sick. So, and I think, the holistic approach that what you're saying about palliative care is so critical because, I mean, every person, I think, needs to understand medicine is medicine, but there are many other aspects that needs to be done, like the psychological support. And if
Mm.
palliative care focuses on the quality of life, and that's really important, right? Now, I know also, doctor, from experience, how I mean, you spoke about the history of palliative care in Christianity. Now, this is why a lot of people have misconceptions in terms of, oh, palliative care is only for Christians, or I mean, how do culture, I mean, affect palliative care in different countries or in different regions from your experience?
Yeah, so different parts of the world, people behave differently. What is normal in one part of the world will be different in another part of the world. That's the whole point of culture.
Yeah.
Everybody is different. We have lots of ways of doing the same thing. So one doesn't mean, just because you have one way of doing something doesn't mean that other ways are wrong. It's just a different approach.
Mm, yeah.
So the main thing I find is that people have this misconception that palliative care is somehow not consistent with their religious beliefs.
Mm,
And I'm not going to name a particular faith, and I've had the privilege. I've worked here in the UAE. I've spent some time in the US. I've spent time in the UK, in the Caribbean, and there are groups of people. There are people who somehow feel that, just because medicine can do so many things, and there are
yeah.
so many cures coming out every day, new
Mm,
technologies, there must be something you can do. I think what they forget is the fact that we are all human, and it
yes.
is part of the human condition that we will die. We will all die at some point. What
Hmm.
is more important is actually, if we have recognition that somebody is coming to the end of life, that actually you recognize it, you
Yeah.
identify it, because
Hmm.
if that loved one doesn't know, and there are important things that they need to say or to do,
Yes.
then we are
Hmm.
denying them that option. So
Hmm.
again, lots of people around the world have different beliefs. Some people say, look, it's not consistent with my religion. I'm not allowed to
Hmm.
take morphine. These are all completely inaccurate. Everything we do in palliative care is to try and make the person feel better. So we typically spend a lot of time talking about cancer patients or patients
Hmm.
who have a terminal illness, but
Yeah.
actually, maybe 20% of the work I do, patients don't have cancer, they're not
Hmm.
dying, but they have
Yeah.
really, really difficult symptoms. And those symptoms
Oh.
negatively affect their quality of life and cause suffering. So the easiest way
Hmm.
to describe palliative care is we are a branch of medicine that is focused on relieving suffering, health-related suffering.
Oh, I love the simplicity of that
Mm.
terminology. Palliative care is about relieving the suffering, right? It's about improving the quality of life. I think
Absolutely.
that's a very good, understanding, because a lot of people will definitely say, no, palliative care is giving up. But see, if they understand that it's all about, you
Mm.
know, helping you with the suffering, relieving that, and of course, improving the quality of life, that's very, very good. Now, doctor, can you share a bit of example from your experience? How does palliative care impacts the quality of life in general? I mean, what have you seen so far?
So, for example, I mean, quality of life means different things to different people.
True. Hmm.
So, we have seen, I have seen people, have much better pain control, so
Hmm.
they can do things. Their function is improved day to day. I have seen people crippled because of pain. For example, I've had patients come into the clinic in a wheelchair. I gave them half a teaspoon of liquid morphine, and they were
Yeah.
able to stand up and walk.
Wow.
It didn't take
Hmm.
all their pain away, but it demonstrated that just a little bit of pain relief can make
Yeah.
such a difference. So I'll
Hmm.
maybe illustrate with a story. So, for example, we had a patient who was referred to us maybe in the first year of me working in Abu Dhabi. He had a cancer of the throat, very,
Mm-hmm.
very advanced, stage 4 cancer. And he had
Mm-hmm.
been in hospital for about 3 months before he was transferred to our hospital.
Hmm.
When he got to us, he was in so much pain. He was miserable. And he was on about 12, 13 individual different pain medicines, and he was still in pain.
Oh.
We simplified his pain medicines very, very quickly, and I put him on a continuous infusion of morphine, just
Mm.
morphine. And
Yeah.
by about 12 hours later that evening, he was almost pain-free. By
Wow.
the next day,
Mm.
he was pain-free. He was actually able to say to us, and he couldn't speak, so he would communicate by writing on a whiteboard. He said, "Doc, this is
Mm.
the first day that I've been pain-free in 3 months." And this is
Wow.
somebody who's been in hospital for 3 months. His wife
Mm.
said, "This is the first time I've seen my husband smile in 3 months because he's not in pain." So these are really, really little things. But why do we go into medicine? We go into medicine to help people. And if you could do
Mm.
something as simple as making their pain better, it has a huge impact on the way people feel. And
Definitely.
this man, he knew that his cancer was not curable. He had made his
Mm.
peace with that. He
Yeah.
actually said to me a couple of days later, he says, "Doc, I was ready to die rather than live with the pain." So
Mm.
it's if you control pain, it is transformative, even in somebody who is approaching the end of life.
Definitely. I think, I mean, some of the people I met in the hospital, the pain is too much. I mean, I met her just today and she was like, Wanda, I cannot take it anymore. I
Mm.
mean, and I think I agree with you how just managing the pain is so transformative to patients, and not just the patients, I think for family members too, because who I mean, I haven't met any family member. When you see a family, a loved one suffering from pain, then the pain is magnified. I mean, you feel their pain too. And I think when you see them getting those relief, then it's really important. Now, doctor, what are also the other misconceptions about palliative care? Because, we spoke about sometimes people think it's already about giving up the medicine or not doing this and that. What are the other misconceptions, I mean, from your understanding and experience?
Yeah. So I mean, there are quite a few. So usually when I talk about misconceptions, one of the first things I say is I go back to my very first day at medical school,
Uh-huh.
and this very learned professor with his glasses at the end of his nose picked up this huge book of medicine, a textbook of medicine. It's called Harrison's, and he says, "Look, this everybody familiar with this book?" Like, "Yes, prof." So this is a huge book. It's about 2-3 inches thick, and it
Mm.
contains all the information about all the conditions that afflict humans. And then he
Mm.
said to us, "How many of these conditions do we actually cure in medicine?" And actually,
Mm.
the amount is a handful. We
Yeah.
fix broken bones. We can treat infection. We can cure some cancers if you catch them early enough. But most conditions are chronic. Most things
Yeah.
we have to manage. So at that
Mm.
point, I realized actually, even then, I had that recollection or the recognition that palliative care is actually quite important because we can't fix most of the
True.
things that affect humanity.
True.
But specifically to answer your question, the myths. So a lot of people think that palliative care is only for dying patients. Not
Yeah.
true. I see
Mm.
as many patients who have curable cancer as there are
Yeah.
patients who have advanced cancer. I may see
Mm-hmm.
a patient, or my team may see a patient once and never see them again. Equally, with somebody with a
Mm.
very advanced cancer, we may
Yeah.
see them multiple times throughout their treatment, all the way through
Mm.
to the end of life. So, palliative care is for people who need help. It is not limited
Mm.
to diagnosis.
That's good.
Another big conception people have is that actually, if you get referred to palliative care, that means your doctors are giving up. This fear of
Yeah,
abandonment.
it's a misconception. Yeah.
Exactly. So actually, palliative care is not about giving up. Most of the
Mm.
patients that we see are still having chemotherapy, still having
Mm.
radiotherapy. Palliative care really is an extra bit of medical support to support the patient, to support the family as they're going through this very, very difficult time. It's not instead
Mm.
of, it is in
Yeah.
addition.
True.
Um, and then
Mm.
the other big misconception people have is that, if I go to palliative care and they give me morphine, I'm going to get addicted. This is a
Mm.
huge fear, particularly here
Yeah.
in the Middle East. So, we use whatever medicines we have at our disposal if we think they're going to
Mm.
help the patient. If people
Definitely.
have very, very strong pain that doesn't respond to simple medicines, then we have to use strong medicines like morphine.
Yeah.
If you have pain and you're getting morphine as part of that cancer treatment, you will not get addicted to morphine. It doesn't happen. If, however, you are getting morphine and morphine type medicines in the
Yeah.
absence of pain or being given it inappropriately, and you're simply becoming high or euphoric,
Yeah.
this is when you end up with a problem with addiction. But
Mm.
if I think I've been doing palliative care since 2010, none of the patients that I have seen become addicted. Doesn't
Hmm.
happen. So again, this is three out of many, many preconceptions people have about palliative care.
Wow, thank you for that clarification. So let me repeat. Palliative care is not about for people who's dying. It's for everybody, right, doctor?
Mhm.
Thank you for clarifying that. This is not about giving up, but this is about improving the quality of care and relieving the suffering. It's
Mhm.
also not about being addictive to any medicine. It's about giving the right care, and I think that's why it's critical to have the right doctor who knows, right? And I think that patient story of yours is a very important story to say. Has been in the hospital 3 months, 15 medications, but it's not helping. So the skill set in palliative care is so critical too. Now maybe doctor, you can also explain how does early palliative care, I know it's not for the dying, and maybe you can explain how when you start the palliative care on the early detection of your sickness is so critical. Why
Yeah.
is it important, doctor?
So yeah, that's a really good question. So we in medicine, in science, we tend to try and do things by what we say is evidence based. So we
Yes, I've
say
heard it. Mm.
this medicine works well because when we did a trial and we compared medicine one with medicine two, medicine
Yeah.
one worked better. So there is very good evidence that early palliative care, and this is a webcast about cancer, so we can focus on cancer.
Yeah.
Um, if you involve palliative care at the point of diagnosis, even if your
Mm.
cancer is stage 4,
Yeah.
patients who have early palliative care have really good outcomes. So I'll go into more detail. This was
Mm.
a study done more than 10 years ago now in Boston, in the US. And what they did was they looked at two groups of patients. All
Okay.
the patients had stage 4 lung cancer. And what they
Mm.
did was they separated the groups into two. One
Mm.
group had standard cancer treatment and palliative care as and when the cancer treatment doctors asked for palliative care. The other group had their cancer treatment, but they had palliative care input right at the very start. And they
Oh.
followed these both groups of patients right through their treatment journey all the
Mm.
way to death. And what they found was some stuff that I'm not surprised about, but also some interesting and surprising findings. So,
Mm.
we expected the patients who had early palliative care to have much better pain control, and they did.
Mm.
With patients
Yeah.
who had early palliative care had overall better symptoms, they had less depression,
Mm.
their mood was
Yes.
better, their overall satisfaction was better. And also the
Mm.
patients who had early palliative care, they didn't have overly aggressive medical treatment, so they didn't all end up on the ICU, for example. What we didn't expect to see was that those patients who had early palliative care actually lived 3 to 4 months longer than the patients who
Wow.
didn't have early palliative care. So, this also
Mm.
addresses one of the myths that I didn't bring up before. There is this
Yeah.
misconception that actually, if you have palliative care, you'll die much faster. Actually, that's not the
Mm.
case at all. We see from working in the hospice, patients who are dying,
Mm.
we think they're going to die within a couple of weeks. We come bring them to the hospice, simplify their medicines, optimize everything, and
Yeah.
actually the patients improve. And then we have to send them home again. So
Wow.
palliative care does not shorten life. We have very good evidence that actually palliative care and early palliative care not only makes people live and feel better, but it actually extends life.
I love that, doctor. I think, because there's so many misconceptions about palliative care. That's why they're not doing it. But I think I agree with you. If there is psychological support from beginning,
Mm.
then you can really expect people to live longer, because I think it's about helping them, right? Heal. I think in your introduction, holistic. This is the holistic approach,
Mm.
right?
Mm.
And I
Mm.
just hope that, it could be broad really, because I've seen, many patients in the hospital who was like, I finished the treatment, but it just spread, it didn't work. And I was like, did you do anything else? They're like, no, do I need to? And I was like, I'm not a doctor, but I know how every emotions that we have.
Mm.
I mean, they're always in that space of why am I sick? Why is it getting worse? Why it's not working? And I think
And I
this is where your role plays. Yeah.
I think that's really important. So I'm not a psychologist. I'm not a
Mm,
psychiatrist. I'm not a therapist. But we spend, if you spend a lot of time looking after patients who are not getting better from their illness, whatever the cause,
yeah.
you know, there is always this thing about how much do you tell the patient?
Hmm.
You know, here in the UAE, I get a lot of families saying, shh, 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 don't say anything to mom, don't say anything to dad. They don't know about their
Yeah.
cancer. And I understand the need for family members to protect that loved one.
Hmm.
If we look at it on the flip side, if you've got somebody who's coming to the end of life, they're asking questions. I'm not getting better.
Yeah.
I'm happy. Why am I still in hospital? Why can't I go
Hmm.
home?
Hmm.
If you actually, and this is difficult, I'm not saying this is easy, but if you're
Yeah.
honest with patients, yes, they will get upset. Yes, there may be tears, but
Hmm.
actually, something changes, the dynamic changes. So before you tell the truth,
Yeah.
everybody's walking around on eggshells. Nobody wants to upset anybody. We don't want to tell the truth.
Hmm.
So this one is telling a little white lie, and then somebody else tells a little white lie, and then
Hmm.
everybody's walking around on eggshells, and then you don't know what to say. On the other hand, if you're very honest and there is a way to have these conversations, be very gentle, yes, people will
Hmm.
get upset. Yes, people will cry, but then all of the angst and all of the stress goes down. And then the conversation flows much more easier. And then you can say, well, okay, this is the reality of the situation. What do you want, mom? What do you want, dad? We can't make this better. Okay, do you want to go home? Shall we try and get you home? And little things like that are important. And it's not improving mental health by giving a tablet. It's by
Yeah.
figuring out what the patient wants. And if you don't
Hmm.
have that conversation with the patient, how will you know what the patient wants? So I'm not saying this in a flippant way. These are not easy conversations,
And I
but this
agree.
is the kind of conversation that palliative care teams are trained to have. So this is
That
why it's so important to have palliative care as part of your cancer services.
I understand now on a deeper level because I agree with you. If I only knew that this is what palliative care is about, I would have said, "Oh, I need a palliative doctor too." Because see, there's so many
Mhm.
misconceptions that just do palliative care or palliative doctor. I really thought it was giving up, but the way you're explaining right now is that
Mm.
how you really help them manage the emotion. Because I agree. I mean, it's a very difficult discussion to talk about death,
Mhm.
illness, and every time you want to protect your loved one, right? But also at the core of it is that with honesty, I mean,
Mm.
it clears up everything and you get more help, you get the right conversation. I mean, the right way to deal with it. Because I think from my experience, I saw how when you're honest with the conversation, then the patient takes care of themselves because they understand that the situation, and they take it into their own responsibility that way. I am sick, but I'm not my sickness, so I'm gonna get healed.
Correct, correct. So we are more than the illnesses. So there are a couple of things that we tend to see. So, when you're fit and healthy, you can speak for yourself. You can make
Yeah.
your decisions. As soon as you become sick, your family
Mm.
takes over.
Yeah.
Your family starts making it. So sometimes, and it is done from a place of love. People want to do the best for that family member, but
True.
sometimes you lose sight. It's the person in the bed. We are making
Mm.
decisions for this person in the bed without even knowing what it is they want, without knowing how they
True.
feel. So it's these are not easy things to talk about, but it's really important to figure out is if it's a patient we're talking about, are they the sort of person who wants to know everything about their condition, or are they happy for their family members to make the decisions? So we
Hmm.
still need to have these conversations. Yes, they're not easy, but that doesn't mean we shouldn't try, because it makes a
Definitely.
huge difference. And even if you don't tell the patient, if you can explain and have clarity and honesty with the family, who's looking
Yeah.
after the patient? The family. So actually,
True.
a significant part of palliative care is not just the patient, it is looking
Mm.
after the caregivers, providing that extra level of support, because we see a lot of caregiver burnout. Somebody who's looking after a family member, once once that patient either recovers or passes away, the burden on that caregiver still remains. And if they haven't had any
Mm.
support, they then become unwell. They then start developing problems. So actually, we have a duty of responsibility to the whole family unit, not just the patient.
I love that, doctor. To be honest with you, in July, I was diagnosed with caregiver burnout. I didn't even know there was a thing. And
Mm.
when I went to the doctor, and then when my doctor saw me, she immediately asked me, "Do you need sleeping pills?" I was like, "Why?" It's like, I think you're already in the verge of something called caregiver burnout. It's like, I never knew there was a thing. So I was like, thankfully, I have the awareness of weight. I think I need to watch also in terms of, my own well being, because how can I take care of somebody if I myself am not well?
Yeah,
And I think
absolutely.
it's important, if palliative care is all about this, then it's more than important to have it from the beginning,
Mm,
because
mm,
it's really about. I mean, I was also at the Jalila Foundation last week. Yeah, there was a lot of discussions about this, and one of the things that was brought out is who are supporting the caregivers,
correct.
because majority of the time the focus is on the patient, but the caregivers actually need support too, but that's the part somehow is on the shadows. But I think I love how you explain how palliative care, I know, really changes the conversation about caregivers and their families too.
Mm.
Now,
So
doctor, I remember also you said palliative care is a big topic. It's 20 sessions in school. I mean, so what are really, the parameters? What are the areas of palliative care that's really, encompassing the whole palliative care when you talk about it?
So I suppose palliative care is basically, supportive care focused on quality of life for patients with a potentially life-limiting illness. So
Mm.
the bulk of the patients we look after have a terminal diagnosis, meaning their condition cannot be cured. This
Mm.
could mean anything from very advanced cancer, end-stage heart failure, end-stage kidney disease, maybe grandparent has dementia and they're
Wow.
progressively deteriorating. So these are all
Mm.
terminal conditions. These are all conditions where we have very good experience over many, many years. We understand what to expect. So we understand
Mm.
the natural trajectory, the pattern of changes that happens when these
Mhm,
patients
mhm.
deteriorate. We can anticipate the problems and prepare both the patient and the family for the problems. Then palliative care also is involved with actually during the dying phase of the patient, when that loved one is coming to the end of life, the last
Mm.
few hours, days, weeks of life, there are things that we see and we recognize. And when we are
Mm.
looking after a patient who is dying, we spend a lot of time explaining to the family what it is we are seeing, how we are
Okay.
working out what is happening.
Mm.
And that also informs our ability to estimate how much time people have left.
Exactly.
Palliative care doesn't stop at death. We often try and
Mm.
support family members after the death of a loved one to make sure they don't have any unanswered questions, to make sure
Yeah.
that they are looking after themselves. And people
Mm.
always have questions. It's human nature. Doc,
True.
I know mom died 6 months ago, but I was just wondering if we did this scan or if we gave this drug, would it have made a difference? These are
Mm.
simple things. It doesn't take very long, but it's really important to provide that support for family members. So that's kind of the core of what we do in palliative and end of life care. But because we are used to looking after patients with very, very difficult symptoms, we spend
Yeah.
a lot of time looking after people managing pain, managing
Mm.
nausea,
Yeah.
managing breathlessness, managing
Mm.
itch.
True.
This is all in the context of cancer. So a lot of the palliative care education that we do is targeted
Mm.
at new doctors, junior doctors, to help them be more comfortable with dealing with death and dying,
Mm.
with being able to recognize when a patient they're caring for is deteriorating, how to recognize and what to say to the family members. So it's a really, really, really broad field, and it is not the responsibility of palliative care teams only. This is the
Yeah.
responsibility of all healthcare providers.
I agree with you, doctor. I think that's also my wish. There's so many questions always in my mind, but when you see the doctor, it's like, can I ask this question or is it another question altogether? And I think I agree with you how it's important for family to understand. It's important to hear it from the doctor because most of the
Correct.
time you always have these assumptions of what if, why, and I think you need those medical answers to really
And
help
I
you.
would also interrupt and say that, a lot of junior doctors complain. I was a junior doctor a long time ago, so I understand the stress, but they get frustrated by having to talk to family members all the time.
Yeah.
Actually, they're missing the point. When you
Hmm.
discharge that person and they go home, who's looking after
Yeah.
the patient? The family. So you
True.
cannot separate patient from that family unit. So that
Hmm.
time that you spend with the family members is not wasted time. It is essential time. And the more time that you spend with them, the more reassuring you are, the more comfortable they will be with whatever advice you give. And the other
True.
exception to that is actually, if we as doctors are not able to answer any question, then how do we expect the patient or the family to be comfortable asking us? This is
True.
our responsibility.
I love what you said, doctor. Now, I know, doctor, there's a lot of advancement in technology right now. Now, how is technology improving palliative care also?
So that is a good question. So everybody gets excited about the new
Yes.
advances, the new developments. So if we think about cancer, there are many, many more cancer treatments. For example,
Hmm.
if you get diagnosed early enough, you have a very good chance of your cancer being cured. Even if your cancer is detected at a late stage, depending on how fit you are, depending on the type of cancer, people survive much longer now with cancer treatments than they used to. So
That,
this diagnosis of cancer is not that death sentence that many people think it to be. So many people live and die with cancer rather than
hmm.
dying of cancer.
Hmm.
Has technology helped palliative care? I think yes and no. There are new techniques and new developments, particularly in the field of pain medicine, different things that we can do to try and improve pain control. New medicines are being discovered all the time. But I think palliative care is not, we're not Luddite in that we're not fixated on the past. But I think, what we do try to do is we try to have very grounded conversations and bring things back to the reality of the situation. So
Hmm.
even if you've had the best cancer treatment in the world, if you have, let's pick a hypothetical situation, you have stage 4 pancreatic cancer with tumor going to the lung, tumor going to the bones.
Hmm.
Even if you've had a really good response to treatment and you've
Yeah.
lived for 5 to 7 years, your life unfortunately will still be shorter because of the effect of
Hmm.
the cancer on the body. That is
True.
neither good nor bad. That is simply the reality of the situation.
Hmm.
So some people say, well, this is unfair. And I get it. Cancer is unfair. Many things in life are unfair. But we also have to be pragmatic. Otherwise, we can't be helpful to our patients. So
True.
this is me. This is how I deal with it. I say, listen, in life, there are things that we have control over and things that we
True.
don't have control over. It is
Hmm.
far more useful for me as a doctor to focus on the things that we have some control over. These are the things that we can do to make you feel better.
True.
Um, these are difficult conversations to have because
Hmm.
people are dealing with mortality. They're dealing
True.
with the loss of a mum or a dad.
Hmm.
But it is our responsibility. This is part of life. This is part of medicine. We can't live forever. So it is part of our duty of care to recognize when the medical treatments are not working. More importantly, when the medical treatments are causing more harm than good,
Hmm.
then we have to stop and say, hang on, what are we doing? Just because we can do this, is it the right thing to do? And this is not a palliative care thing only. This is medicine. I used to have these conversations when I did internal medicine.
Yeah.
The difference is palliative care. I spent 4 years after my medicine training doing nothing but palliative care. So you get very good and very skilled at having these conversations. That's the benefit. So my job, really, the way I see my job, is to work with all my other colleagues in internal medicine, in oncology, in surgery, and help support them when they have these difficult situations. I will call a surgeon when I need surgical input. Likewise, if they have these difficult conversations or they're not sure about which way things to go, how best to control the pain, they ask for my help. So it's just being aware that, everybody has a specific skill set. Everybody
True.
brings something different to the table. It's about being very open, being respectful, and giving people a space that is safe to be open and say what it is you're scared of. I don't know what we're doing here. I need help. And this is where
True.
palliative care often gets called in, when people don't know what to do. They think the patient might be deteriorating, but they don't want to say it because maybe they're scared of using the word dying. They don't want to upset the family. I
True.
understand that. If you have doubt, ask a colleague who's more experienced. That's the way I think about using palliative care.
That explanation is very good, doctor, because I think, I mean, as a family member, I mean, I was like, are there any other more doctors that I need to see? Have
Mm.
I done, everything that I need to do? And I think, I mean, today there's so many questions answered for me in terms of palliative care and how it can help the patient, the family members. Now, doctor, also in terms of the palliative care, what's your best advice to patients? Because even to the family members, I mean, what is your, because a lot of people have these misconceptions, what is your best advice to them? What do they need to do if they really feel that they need, I mean, I think the good thing here is that your this is the right time is depending on you. But if you were given an option, I mean, you've seen so many patients already from your experience. I think it's also a question is, when is enough enough? Because, one treatment after another. And I think from your experience, when is enough enough? And what's your best advice to those
Yeah.
patients and family members?
I like your question, and I like the way you phrased it. When is enough enough? So the way the human body works is that the human body can tolerate quite a lot of insult, meaning,
Mm,
you can fall down, break a bone, recover. You can have a chest infection, you recover. Have
yeah.
pneumonia, recover.
Mm,
But the way the body works is that the more insults, the more problems that the body accumulates, the harder it is for the body to bounce back, the harder it
mm,
is for the body to recover. As we get older, we accumulate more problems. So
true.
let us take a hypothetical case. A 75, 80-year-old granddad who
Mm,
really reasonably good health, but has smoked for a long time, so his lungs are not in good shape. He's
mm,
diabetic, his kidneys are not in good shape, and then he gets diagnosed with pancreatic cancer. But he's in good shape, so we start
mm,
cancer treatment, and he tolerates it for maybe a year or two, and then every time he has chemotherapy, he ends up in hospital for 2 weeks.
mm,
Every time he recovers and he leaves hospital, he's
mm,
not quite as good as he was before he went to hospital. They give the other cycle of chemotherapy, he ends up in hospital again.
mm,
He recovers, and every time he goes out of hospital, he's a little bit less well. And then over the next couple of months, you realize, actually, hang on, 4 or 5 months ago, granddad was able to walk. Now he can't. So the more you insult the body, the more pressure you put into the body, the harder it is for the body to cope. You can
mm.
continue giving all of the treatments, but the point at which the treatments are causing more problems and the
Yeah,
risks and the side effects of the treatments outweigh the benefit, you need to
true.
stop. You also
Mm,
have to say, at what point is enough enough for the patient? So some patients, and I know this is not a popular thing, but I have had patients say to me, for example, patients on dialysis,
yeah.
patients who have kidney failure and they are dependent on
Mm,
dialysis. You can stay on dialysis for many, many years. Some
mm,
patients, as they're approaching the end of life, they don't tolerate their dialysis sessions. Their blood pressure falls. So rather
yeah.
than having dialysis 3 times a week, they have it twice a week. and then once a week, then you have to start giving medicines to raise the blood pressure so they can even tolerate their dialysis. Okay, more important, the patients would say to me, Doc, I don't think I can do this dialysis anymore because
Yeah.
I'm living only for dialysis. I'm not living for me anymore. All I do is focus on getting my dialysis. I come home, I recover for the 3 or 4 days, and then I have the next dialysis session. So the balance is not there anymore. I'm only living for the treatment. That is another important point. If your patient or that loved one says to you, what is the point in this? I'm living for treatment. I'm living for chemo. I'm spending more time in hospital than I am at home. I'm not enjoying this. You have to stop and ask yourself, are we doing the right thing? This doesn't mean you're calling into question the doctor's capability or that you're saying that medical team are not good, but this is human nature. As we get older, as we become more frail, there often comes a tipping point in the balance.
True.
And that tipping point is that the treatments are causing more harm than benefit. That's often a good point to say, I think we need to stop.
Thank you for that, doctor. I think it's all about always weighing, right? Putting the balance. And I think you put it correctly. If the risk is more than the benefit, then that is maybe when it's time to call it off. Now, doctor, I learned so much already. Imagine 54 minutes already together. I think I want to thank you. There's so much that I learned today. And I hope there'll be more doctors like you. I mean, that could, I think I understand how you both, you're not a psychologist, which is I get it, but I think that role is very important of, giving information to the family. It's like a psychologist doctor somehow because you
Mm,
have that, physical expertise in terms of the body, but you also have the emotional support,
mm,
which
mm.
actually a palliative doctor will give. Now, doctor, can you please invite people if they want to get in touch with you? What's the
Mhm.
best way to do that?
Okay, that's very kind. Thank you. So I'm based at Bajil Medical City in Abu Dhabi. That's in Mohammed bin Zayed City. But we also, funnily enough, do clinics in main Bajil Hospital Abu Dhabi, Bajil Alain, and Bajil Hospital in Sharjah. So that's where we are based. Um, the Bajil.com website has access to all of the hospitals, and actually, if you just type palliative care Bajil, our team will come up on the search list. I'd like to say thank you.
We're gonna put doctor back on stage. Yes, doctor, we lost
Sorry,
you.
sorry. Willow, sorry. I
Okay,
was
no
going to
problem,
say
doctor.
we are holding the very first conference in the Emirates, in the UAE, dedicated to palliative care. This is the very first conference supported by Burjeel Holdings and dedicated 100% to the full, I suppose, the full range of palliative care. And this conference is being held at the Rosewood Hotel, October 19th, 20th, and it's over 2 days, the Saturday and the Sunday. The first day, Saturday, we are very, very lucky. We've got really, really excellent world-class speakers. We have Dr. Raja Gopal, who's basically known as the father of palliative care in India. He's
Oh
a double
wow.
Nobel Peace Prize nominee, world-class expert in palliative care. And the first day is many, many talks and presentations about palliative care. The second day, we continue with some more talks, but the main focus on Sunday is a workshop. So the workshops are looking specifically at physical and psychological symptoms that we encounter in palliative care. And it's a chance for everybody to ask questions. So we're trying to make this conference very, very interactive. So the conference is extremely oversubscribed. We have something close to 500 attendees registered for in-person, almost
Wow.
3,000 registered virtually. In-person registration is closed, I'm afraid, because there are so many people. You can still register online. If people want to sponsor the conference. This will allow us to open to more in-people attendees. So please get in touch if you're interested in being a sponsor. But yes, thank you very much for the opportunity to wave the flag for palliative care. Very kind of you.
Thank you, Doctor. It's an honor to have you. Can we also share, Doctor, your LinkedIn account and your website, please?
Please, go ahead.
So actually here we have Dr. Nijhawan's LinkedIn account. Go to LinkedIn. Okay, just look for Nijhawan and you can find him. Also, Doctor have a website, right? I think we're gonna flash this website.
Yeah.
Actually, it's the birthday, Doctor. Thank you, Doctor. It's such an honor to have you. We are very blessed. I learned so much today. Let me recap the episode for today. With Dr. Neil, we learned about what palliative care is about. It started with Christianity, but the best thing, it's not limited to that. It's not about giving up. It's not about for people who are only dying. It's also not about being addicted. It's about relieving the suffering. It's about putting the quality of care to help the patient, to help the family members. And today, we would like to thank you again, Dr. Neil. Thank you. This is the episode of the Cancer Conversations podcast with Coach Wanda. I would like to thank, of course, my team. Let me just thank you again, Doctor. I want to thank one of our partners is Bailiwick Academy sponsoring this podcast. Thank you. 𝐀𝐿 Social Media Marketing, thank you. Also, again, because it's Cancer Awareness Pinktober, right? We have some special announcements in the end, but I hope you join me next week. I have again another doctor guest. She's gonna talk about cancer care in the Philippines. We're going to talk about how can you find it affordable and high quality cancer care in the Philippines. We will also have this remember, if you want to get yourself checked, women over 40, there's a free mammogram here in Dubai. Go to Advanced Care Oncology Center, book yourself, to make sure that you get it free. Now, if you don't want to go to Al Farjan, to Advanced Care Oncology Center, the Prime Medical Center is offering for only 250 and 300 a special package. You can get yourself checked. Please do visit this one. And again, I would like to invite you to the Men to Be Well Summit. It's October 18 and 19. My session is on October 18, 3:50 Dubai time. I'm going to speak about from exhaustion to evolution. How can you break free from burnout? So thank you again for those who are watching us live or on replay. This is the Cancer Conversations with Coach Wanda. Every week I go live on LinkedIn with guest healthcare experts, cancer survivors, companies and organizations who are in the business of helping people detect, treat, and cure cancer. If you want to partner with us, please message me or my team at 𝐀𝐿 Social Media Marketing. This podcast is produced by 𝐀𝐿 Social Media Marketing. If you want to start your own podcast on LinkedIn, and if you want to stream it live on Facebook, Instagram, YouTube, or Twitter, we will do that for you. Thank you again, Dr. Neil. Such an honor to have you. Thank you, everybody. God bless you.